Morning, everyone. It's my pleasure to introduce our speaker this morning. It's Dr. Sestero. He did his undergraduate and medical school work at UC San Diego, did his residency at UC San Francisco, where he made the life-changing decision to join the Navy. He spent 10 years in the Navy, did 7 deployments after his residency, and then came back from Iraq and went to USC LA County for his Trauma Critical Care Fellowship, where we were fortunate to recruit him here, and he runs the Trauma Critical Care Fellowship here as well. So with that, Dr. Sestero.
Thanks very much. Right off. All right. And can anyone hear me? I'm trying out this microphone. Sound good? All right. Thanks, everybody. Good morning. So the genesis of this talk, I know people have asked me, like, where do you come up with this topic? And I think I was rounding in the ICU during this week, and I went home and I was watching TV, and I saw a commercial for the new iPhone. And it was about a year ago, I think. And it said that the computing power in your iPhone is more than NASA had in 1969 when they put people on the moon. And I thought, wow, that's incredible. You know, here I am rounding in the ICU, still with a paper, rounding the same way I did in medical school, where you round at each room. Nurses have the data available to you, but you're still rounding the same way. Nothing really progressed since that time. So first I wanted to verify if that's actually really true. Did NASA have less power than your iPhone back in '69? It's true. Apollo 11 was the first space flight to land on the moon. This is Buzz Aldrin and Neil Armstrong. That's 356,000 miles round trip. Left in July 1969. Took about 8 days to get there, land on the moon, and come back. And at that time, NASA didn't really have computers. It was actually when the first microchip got invented. IBM made a computer for NASA. Each one was about the size of a car, cost about $3.5 million each, and their total memory was about 8 megabytes. This presentation alone was 46 megabytes. So incredible that that's a NASA computer back at Goddard Space Center. On the actual spacecraft, on the lunar module and the command module, which got them there, got them on the moon and back, their guidance computer, also developed by MIT, had 32 kilobytes of memory. This picture of the rocket right here actually is 46 kilobytes. So incredible that that kind of technology could put you on the moon and back. And here we are, 40, 50 years later, we're still in the same thing. And we just haven't taken the computational advances to what we do. A toaster today has more computing capability than they had on that spacecraft. So if you have a toaster, you can make it to the moon and back. So here we are in 2017. We have artificial intelligence. Some of you may be familiar with Watson. That is an IBM computer system, which is actually designed for Jeopardy. It's designed to actually process natural language. You can ask it questions just like you would your peer or somebody else. It has machine learning. It's able to learn from its mistakes and update its knowledge base to make better predictions in the future. It actually was tested against 2 of their major Jeopardy winners in 2011 or maybe 2012, and actually won $1 million. And you can see it actually won fairly easily with 300,000 and 200,000 the other 2 competitors. It can process 500 gigabytes per second, which is about 100 million books in 1 second. And if you read articles, you talk about artificial intelligence, how it's going to change medicine. Forbes article in 2014 said Watson may soon be the best doctor in the world, and we'll see more about that later on in the lecture. And maybe we need the help. So it's been well known that there are mistakes made in medicine. ICU is no exception. There is a systematic review of autopsy studies for ICU settings and looking at diagnostic errors. 31 studies, 5,800 autopsies, and they took a look at autopsy-confirmed diagnostic errors made in the ICU. Excuse me. They found that 28% of all autopsies in these studies have more than 1 diagnosis. Only about 8% potentially lethal, but still it's a significant number. Most commonly it was vascular events, either hemorrhage, MI, PE, and infections were also commonly found, whether it's bacterial, fungal, aspergillosis, they were kind of ranging. But it's a fairly significant number. If they extrapolated this number out to all of the deaths in the ICU every year, they estimated that maybe up to 40,500 deaths per year with misdiagnosis. So maybe we need some assistance in the ICU. So today I'm going to kind of talk about where we are with clinical decision support systems and ability to use computers and algorithms to help us in the ICU. Talk about some of the basic definitions, talk a little about the EMR and why we are where we are. Clinical decision support systems. We'll talk about just 3 areas because there are just too many to cover in 1 hour, mainly sepsis, antibiotic stewardship, and information displays. and a little bit on predictive analytics, using the ability for computers to look at data to predict the future and how we can use that in clinical care. And I'll specifically talk about the Rothman Index, which we have available here at University Hospital. No disclosures. So definitions, the EMR is basically a digital version of paper records. There's nothing really magical about EMR. It contains medical and treatment history in one practice or setting. It's different from the electronic health record, which is supposed to take it from all areas of medicine, so different hospitals, clinics, population statistics, et cetera, to really give you a global picture of an individual, but really it's just a digital version of paper records. A clinical decision support system, CDS or CDSS, is an information technology system, which is healthcare related, which assists with clinical decision-making tasks. It doesn't make them for you. That's how they actually started when they first designed them. They actually just made you or gave you the diagnosis. This one's to assist you as you go through the process. It's really supposed to be helpful for us. I know we don't always think this is helpful, but that's what it's supposed to be. That's how it's designed. And then predictive analytics, using statistics to make future predictions using current historical facts. This is used in multiple areas, not in medicine. Medicine's just starting to use them. Your credit score is using predictive analytics. It predicts your likelihood of failing to pay a debt or a loan. It's used in aircraft industry. It's used pretty much everywhere else. Economics. Medicine is just getting started. So the history of EMR, actually the idea of an EMR has been around since the 50s, since computers started being talked about. Just technology wasn't there. 1972 was the first EMR system out of the Regenstrief Institute in Indianapolis. It's actually still in existence. They still use it. But it was very expensive as with any new technology, so really no one kind of bought into it. As the 80s came along and they started making lower cost personal computers, EMRs were able to spread, but really this was limited to large hospitals, small clinics, and small private practice settings just didn't have the money to get into it. In the 90s, it started to become more web-based. The internet started to develop. The Institute of Medicine in 1991 recommended that all physicians or all medical practices should have a computer in their practice by 2000. So this generated a little more interest. And then really it was 2009 when the government got involved as far as after the Great Recession and the American Recovery and Reinvestment Act. As part of that, the Health Information Technology for Economic and Clinical Health Act came out, that they actually really promoted the use of EMR. They actually put up $27 billion for the use of ER implementation. And along with that, if you used your EMR, you have to use it for quote-unquote meaningful use. What does that mean? It means you're using it to improve your processes, improve health disparities, improve outcomes, improve communication with your patients. You have to have some measurable outcomes in order to get that money. So how do physicians feel about this? The American Medical Association was interested in finding out what makes physicians satisfied or not. So they actually asked about this in 2012. They went to 6 different states, including Texas, about 40 or 50 practices. And they went out and did surveys. They interviewed a bunch of physicians, and they came up with a number of ideas about the EMR from various groups. They asked them how it interferes with your practice and how it benefits your practice. As far as interfering, I think most of us in this room that have used EMR will identify many of these. It's time-consuming data entry. It takes time to just put it in. It's not intuitive interface. You can tell it's not designed by Google or Apple. It's really just not very intuitive when you use your EMR. It interferes with face-to-face care. Anytime you walk through the ICU, you can see nurses spending more time documenting that they are interacting with patients. Too many alerts that people end up ignoring, called alert fatigue. There's a mismatch between the meaningful use criteria promoted by the government and the clinical practice, which we think is important. The cost of EMR purchase, initial startup, as well as now the contract for the upgrades is very expensive. And the templated notes degrade the quality of clinical documentation. The free text ability really isn't picked up by the EMR very well, so you have to use templates so it's used so they can analyze the data, but really most most physicians feel it degrades the quality of the documentation. How does it improve personal or professional satisfaction? Well, I think probably most of us will identify with these two. It improves the tracking of your guideline compliance, because now you can put it as part of your system. And disease markers as well, so CHF, diabetes, et cetera. Mainly for primary care practices, they felt this was better. Better communication with patients and between providers. Ability to go on the internet, communicate with your physician, transfer lab results, et cetera. And improved access to patient data. Now you can access data not just at the bedside, as we used to when I was a medical student, but now you can access it pretty much anywhere, on your phone, computer, at home, et cetera. So as far as clinical decision support systems, there's multiple definitions of what this means. The most general one I could find was one on top, which it basically links health observations with health knowledge to influence your clinical decisions. So very, very broad, and it has multiple types. So it's all kind of put in one big basket, which makes it difficult to study, as we'll see as I go on. But the two that are bolded are the ones I'm going to talk about today. The most common one is expert systems. So these are systems that are in the software that help you with either diagnosis or treatment. There's information displays. So how is that information transferred to you? Is it a graphical representation, numerical, just numbers? So how the information is transferred. Medication dosing, particularly with antibiotics. Order facilitators, as you fill in your admission orders, maybe a template comes up and fills in the orders for you, and maybe some boxes are pre-checked. Point of care alerts. If someone has a high potassium, it sends an alert to the intern, resident, attending, et cetera. And then workflow support, medication reconciliation, et cetera, to help you kind of go through your day. So all of these are packed under CDSS, and studies kind of look at them together, which makes it difficult to tease what's important and what's working out. The general goal for all of these is getting the right information, so what it is that you want, to the right person. Is it the nurse? Is it the attending? Is it the resident, et cetera? In the right format, something that you can use easily and understand the data. Through the right channel, is it through your phone, through your computer, et cetera? And at the right time. Is it before you make the order, after you make the order, or make the change? So multiple goals, not well achieved yet, as we'll see, but this is the ultimate goal of CDSS. And do we need it? I mean, it just really complicates things. I remember things being a lot easier 10, 15 years ago. Well, maybe we do. There's an estimate that over 2 million medical facts are learned by the time one practices medicine. I've probably forgotten about 99.9% of those. Medical literature doubles every 19 years, and in some areas that are, especially the ones that are new, say like genomics, and maybe every 22 months it might double. It's very hard to keep up with that amount of data. Over 3,000 molecular diagnostic tests on the market. And how do you know that which one you need to order? You don't even know if it's available. That's a lot of tests to be able to keep track of. And as genomics progress, personalized medicine progresses, all this information is just going to exponentially expand. It's going to be difficult for an individual to kind of just have that all in their head. And if you listen to the government or read the government, according to the Health and Human Services, go to their website. This is just from yesterday. CDSS have the ability to significantly impact improvements in quality, safety, efficiency, and effectiveness of healthcare, which is really what we want to do. So the government believes in it. They're promoting it. So maybe we do need it. So I'm going to talk about expert systems to start off with. Again, this is the most common type of CDSS. It's really designed to help you with diagnosis or treatment planning. Really, is to help you, not to make it for you. There's really two types. There's one is knowledge-based. It follows a predetermined set of rules, such as the alert system. Basically, you tell the computer if the potassium is greater than 6, if potassium is greater than 6, then send a page to the attending on call, letting him know that that's occurring. Fairly straightforward. And then there's a non-knowledge base, which is much more complicated. This is probably where medicine is going to go. We're still in the very early stages. This is where Watson comes in, where artificial intelligence and machine learning comes in, where you basically give it a bunch of data, it determines relationships between symptoms and signs and outcomes, and it then uses that information to predict that in the future. You don't know how it made it, but it tells you that the data supports this diagnosis. We'll talk a little more about each one of those. So a knowledge-based CDSS. This is the earliest design for clinical decision support. It really was intended to just replicate how we think. If you have an abnormality and it correlates with a certain abnormality that you know about, or disease process, then that's the diagnosis. It's based on predetermined rules, so the if-then that I just discussed. There's really 3 components to it. One is a knowledge base, and that's basically your encyclopedia, your book, your diagnostic reference that has all the information about medicine in there, has your guidelines in there, et cetera. Then there's the inference engine, which is really the brain, and it correlates the data input, which is all your patient variables, your age, your comorbidities, your operations, et cetera, with the knowledge base, and then it tells you that patient has X, Y, or Z. Then there's a communication method, the way you put in the data and the way it's then relayed to you. Those are the basic 3 parts. The challenges are, as far as the input, as far as putting the data entry, well, it relies on certain keywords. So if you don't use the particular keyword that the software is designed for, it's just not going to pick it up. Between CDSS systems, so there are multiple on the market that are trying to gain market share. The vocabulary is not always the same, so you can't really put all that data together to make one master one. So that causes challenges. The inference engine, or the brain, It really requires validated rules. So we all know in this room that medicine is not an exact science. We still have difficulty defining ventilator-associated pneumonia. We discuss it every day on rounds. Do they have it or do they not? You can't tell that to a computer. It's either a 1 or a 0. So it's very difficult to come up with a validated set of rules that the computer is going to use. And then from a knowledge base, the medical literature, along those same lines, it's uncertain. There are contradictory studies out in the literature of different validity, different strength. How do you tell a computer which one to depend on? And also it needs to be continuously updated. The non-knowledge-based CDSS, again, is probably where we're going to be going with medicine. This is more the machine learning or artificial intelligence. And this is mainly designed by pattern recognition, not so much rules that you put into the system. It's really more of a neural network, trying to be more like the brain itself. It has nodes, which are related to neurons, just like the brain, and weighted connections, which are nerves. And what you do is you basically plump in a bunch of data, population statistics, into a machine, let it develop its own algorithm, and then over time, as more data is put into it, it can make better correlations between symptoms and signs and diagnosis. Anyone's used a CRI with Michael Johnson, the little black, orange box that we use down in the trauma bay, that's machine learning. We don't know how it determines its results. It basically just collects data and develops its own algorithm. So it's basically a black box, which is going to be difficult for us over time to really, I think, trust, because you don't know how that information was determined. The advantages are that it continuously improves, it learns, and it gets better over time. There's no need to form rules because it forms its own associations with the data. Disadvantages are you have to train it. So you have to put in this data, see what it develops as far as a diagnosis, then say whether that was right or wrong, and then it goes back and redevelops a new algorithm. So you have to train it. It takes a lot of time, takes a lot of effort. And the algorithm, again, is unknown. We don't know how it came up with that answer. This is an example of a knowledge-based system that's been used at Mass General since where it was developed back in the 1980s. They've used it to today. It's called DXplain. It's fairly straightforward system, and like I said, they still use it with residents now. It's available on the web, so other locations can use it. Essentially, you put in some basic variables, sex, age, how long they've been in the hospital, and then you put in several symptoms, so anorexia, movement pain, back pain, they were recently in Mexico, etc. The program will then come up with new suggestions as far as what you may want to potentially add, which will then narrow the diagnosis. It'll actually point out things that might be important. If it thinks the patient might have lung carcinoma, it'll ask about vocal cord paralysis because it very strongly supports that diagnosis. As you go through, it'll tell you common diseases and also rare diseases. And as you add more data, add sheep exposure, fever, back tenderness, it'll actually narrow this down a little bit more. Plus marks will tell you it's a sufficient evidence to support the diagnosis. If you have 2 marks, it very strongly supports the diagnosis. If it has a exclamation mark, it's something that really needs to be urgently addressed. And over time, it can help you with especially rare diagnoses or diagnoses. This has been looked at. There's a study out of actually the same institution, Mass General, taking a look at the impact of using this DXplain system in some difficult, what they felt to be difficult diagnoses. So they did a prospective study asking PGY1 residents in 3 areas, ovarian cancer, colon cancer, and appendicitis. These are actually real cases that they then sent out. They did it all online, and they basically came up with their own differential diagnosis and treatment plan initially, and then they did the same thing using the DXplain computer system. Then they measured improvement in diagnostic ability and their management decisions. And if you take a look at their data, from a diagnosis that was not on the list to then adding it on the list, for ovarian cancer, 65% of the residents did that, colon cancer 20%, and appendicitis 25%. So they did not have the right diagnosis on the list initially. After using it, they added it. As far as taking it from off the list or having it as their initial altered diagnosis to making it their #1 correct diagnosis, 30% of the residents with ovarian cancer, 35% with colon and appendicitis, and 35%. And as far as management decisions, the third row, not having it on the list at all to then after using the computer program and then having it in their management plan, 65% for ovarian cancer, 15% for colon, and 20% for appendicitis. Most of them thought in a survey that it was helpful, but overall 20 to 65% improvement in differential diagnosis and management using the computer system. This can also potentially have a benefit on cost. This is actually from the Mayo Clinic using the DXplain system. And they took a look at medicine residents as well over a 6-month period. They trained them in using it just in general. Over month 5 or 6, when they were kind of spun up on it, They then took a look at just cases that had difficult DRGs, and this was decided by 3 or 4 of their faculty. They wanted to take a look at just the challenging cases and seeing whether there was a cost benefit using a computer system. So they had 564 in the challenging cases using the computer system versus control in the year prior, which had over 1,000. And when the residents used the computer system, total charges for these difficult cases were about $1,200 lower. The Medicare Part A charges were about $1,000 lower, and the cost of service to the hospital overall was about $1,000 lower. And they thought that they extrapolated out to their general population, and with these same DRGs, they projected a savings of about $2 million a year with this computer assistance. So those are not critical care related, this is critical care talk, but that gives you a little bit of data as far as how this can be used. Unfortunately, in critical care, I was hoping to find the program that's really used everywhere else, just not here, that is going to change our management. Unfortunately, that just doesn't exist. There's really not as well developed in critical care as they are in outpatient settings and in general wards. There are no accepted standards as far as what program to use in any of these areas of focus. Most of them are homegrown. Most of them are developed within the location. They either have a computational office or some affiliation with individuals that look into these kinds of things. But there are 3 main areas of focus I'm going to talk about today that are critical care related. One is sepsis, antibiotic stewardship, and then clinical information displays. Let's talk a little about sepsis. It's a leading cause of death in the U.S., major healthcare problem, not just in the U.S., but worldwide. Cost to the U.S. about $14 billion a year. It's been well shown that early identification and treatment is important. For every hour that you delay in giving antibiotics, there's an increase in mortality. So early identification and treatment is extremely important. So sepsis alerts have been created using the EMR data. That if you tell it to look for certain things, then alert somebody that this patient may have sepsis. Although we've moved away from SIRS criteria, this is what most of the studies have been based on, so systemic inflammatory response syndrome criteria. And the 4 listed here: heart rate, temperature, respiratory, or white count. And when you tell the computer that when 2 of these are elevated, send an alert. It'll send a nurse or physician alert, which then verifies the data, and then it gives you intervention options or an order set that you can then automatically fill out. This is kind of what it looks like. This is just an example of one of the programs that's out there. It's a possible severe sepsis nurse notification. They identified 3 SIRS criteria of tachycardia, elevated temperature, and elevated respiratory rate, and they also identified organ dysfunction with hypotension. This generates an alert to the nurse, who then has the option to then forward it along if she thinks it's valid. Maybe it was just a bad blood pressure draw, et cetera, or blood pressure reading. And then she can send it along to maybe a physician. There's a severe sepsis alert. The following information suggests this patient may have severe sepsis. Click on the lower button to complete the document. If you're not the attendee, you can bypass. Once you get to the next document, and I know this is a little bit hard to read, I try to get a better copy, but I'll tell you what's on there. On the top, it gives you the alert, what generated the alert we just talked about. Then it asks you if there's any other evidence of organ dysfunction. Is there respiratory, is there hypoxia, is there metabolic abnormalities, renal issues, et cetera. And then you can discuss whether there's blood cultures or lactate pending. And then there's orders, a bunch of check boxes that you can click for orders regarding blood cultures or lab draws, including lactates. So there aren't too many studies that actually looked at this. The best data out there is probably the systematic review from 2015, relatively recent. And they really want to look just at sepsis alerts, and they want to look at 2 things. One is how well does it identify sepsis, and how effective is it as far as an alert system. There were 8 studies, only 1 randomized controlled trial. Most of the data was fairly weak, all single center, all academic. Most used systemic inflammatory response syndrome, plus or minus evidence of shock. The positive predictive value, so this is if it's a sepsis alert goes off, what's the percentage of those patients that actually had sepsis? Very low, only 20 to 50% of those patients actually had sepsis when it went off. The negative predictive value, if the alarm doesn't go off, they don't have sepsis, was actually very high, 76 to 99%. But the positive predictive value is probably the most important aspect here that just doesn't predict it very well. They did find, and the patients that did use CDSS, they had improved antibiotic escalation. They gave more antibiotics more frequently, more fluid resuscitation, and better diagnostic testing. The ICU, not so much. It was more identified more in the wards of the ED. The ICU is already a setting where maybe the patient's already septic when they get there. There's more visibility. There's more physicians around. Really, you probably don't need the sepsis alert. It was found to be more effective down in the wards in the ED. However, no difference in mortality or length of stay, which is really the ultimate goal in reducing or identifying sepsis earlier. and they identify some potential harms. Alert fatigue being one of them. When this alarm goes off and it turns out they don't have sepsis, it can be very frustrating. People tend to ignore it after a while. Patients get excess fluids as soon as the alarm goes off. If the patient may have sepsis, fluids are the next thing that are usually given. Excess antimicrobial use, same thing. And potentially increased labs that are necessary. The systematic review did not show this, but there were some studies that showed that when you use the CDSS, there are more lactates drawn, which is maybe good. However, there's a higher percentage of normal lactates. So maybe they didn't need them in the first place. So unclear whether it is helpful. Their conclusions were that sepsis alerts improve a subset of process measures, but at the cost of poor predictive value and no improvement in mortality or length of stay. Insufficient evidence for use of sepsis and alert systems in the ED. That's not that they aren't potentially helpful, it's just the data just isn't there to support it. And due to limited studies, unable to make strong conclusions regarding the clinical benefits and cost effectiveness of automated sepsis alerts. So bottom line, in 2015, we still don't know whether these are helpful or not. A little bit of antibiotic stewardship. So the World Health Organization in 2010 said antibiotic resistance is one of the 3 greatest threats to human health. Antibiotic stewardship programs are promoted by multiple organizations, including the Infectious Disease Society of America. There's multiple types of interventions you can make to control your antibiotics. One is using clinical decision support system. We'll talk about that in a second. Mandatory ID consults for certain antibiotics or for all infection. Restricted antibiotics where only certain people can order them. A mandatory 3-day antibiotic review where after 3 days you have to go review your antibiotics, maybe with infectious disease. There's multiple different programs that are in place. This in the study we'll talk about kind of took a look at all of them. The clinical decision support system involved with antibiotics, they take your patient data, they take population statistics regarding the infection of interest, and then the computer tends to guide you in it. There has been pretty well shown that it has improved outcomes, decreased antibiotic usage, and some cost savings. But what does the data show? We'll talk about that in a second. This is an example of what an antibiotic stewardship program might be. This is for a patient who's on piperazine, tazobactam, and flagyl, both which have anaerobic coverage. Unless the patient has an undrained abscess or has both an infection and C. diff, one of the anti-anaerobic antibiotics should be discontinued. Provides your literature for you to review. There's 2 studies listed here. And then it goes on to give you an option to either continue both antibiotics or discontinue it. If you decide to accept the recommendations, then after you've discontinued one of them, then it goes on. If you decline it, then you have to explain as to why. And this will come into interest a little bit later, because if you do decide to decline with the computer and the best evidence told you to do, does that set you up for potential liability? And we'll talk about that in a little bit. So again, the studies for this, it's hard to tease out whether clinical decision support systems by themselves are good for antibiotic stewardship. This is a systematic review from 2011, which took a look at all intervention types. So the 3-day automatic review, mandatory infectious disease consult, et cetera. From 1996 to 2010, 24 studies, only 6 involved clinical decision support. And out of all those studies, there was only 1 randomized controlled trial. So again, weak data. But when they took at all stewardship interventions of any kind, they found less antibiotic use overall, 10 to 40% drop. Lower costs, about $5 to $10 per patient day. Shorter therapy of antibiotics, and fewer adverse events or inappropriate antibiotics were given. So fairly good outcomes. When you take a look at using clinical decision support or the computer system by itself, again, decreased antibiotic use, and interestingly, without a concomitant increase. So in the other studies, if you did see an antibiotic drop when you used some kind of system, however, it was just replaced by a different antibiotic. Someone just chose something that was not on the restricted list. When you use the clinical decision support system, actually there was not a substitute antibiotic given inappropriately. So improved appropriateness was found with clinical decision support, fewer adverse events overall, and overall a beneficial effect on institutional antibiotic resistance. So overall, using CDSS, there are benefits. Lastly, I want to talk about information displays. It's been shown that human brains have difficulties processing more than 5 variables simultaneously. And anytime you walk into a code and you see in the monitor there's 8, 9 variables up there, and then someone's telling you the ABG values and you're trying to assess the patient, there are multiple variables we're trying to process every day, but particularly during those high information settings. Current displays have been designed. The first display was an EKG, and it's only progressed from there. So one value, one display. And it's just continued from there, heart rate, blood pressure, et cetera. But one sensor really is one indicator. There's really no integration of any of our systems for the most part. Clinical decision-making requires integration of multiple information sources, and graphical displays where all that data can be provided either from in a shape or colors or integrated through an algorithm can actually help potentially in taking that information and analyzing it a little bit faster or easier. For an example, I don't like using a lot of the aircraft industry for comparisons because bundles have just been done for so long, but you've got to give it to the aircraft industry. They have progressed immensely over the last 50, 60 years in multiple areas. Information displays is one of them. There's from the F-100 Super Sabre, this is the first supersonic Air Force fighter used over Vietnam. Significant for the most part from 1954 to 1971. And there's the cockpit display you can see here. So multiple displays, altimeter, vertical flight, speed, altitude, etc., airspeed. But for every data point, there's really one display. Not too many values there, and over time there have been more displays made. But compare this to Boeing 787 Dreamliner from 2017. And the first thing you probably notice is the lack of each of those gauges, the lack of each of those displays. What they've done over time is really do graphical representation of the same amount of data, or if not more. These are very, very complex mechanisms with actually a lot more data to show than back in 1956. Pretty much everything is just generated either a color or a graph. If something alerts them, it'll change color, it'll pop up, et cetera. But hopefully everybody can appreciate the advances that have been done in the aircraft industry with graphical displays. Let's compare that to medicine. So this is pretty much how data was collected in the 80s and 90s. So when I was a med student, the nurses in the ICU would just have a big tri-fold sheet that they would just collect for 24 hours. And there were just 24-hour columns, and at each one they'd put the blood pressure, vitals, all the labs would be on there. So in one place, you have all the data. If you want yesterday's, just flip to the sheet behind. This is how it was collected back then, a lot of numerical representation. This is what we do today, right? This is from Sunrise. So this is the graphical representation on Sunrise. There's an option where you can actually pull up kind of the major view of the entire patient. The graphical representation here, hopefully everybody agrees that it's not the same as it is on the Dreamliner aircraft. It's basically just graphical representation of some data, but still difficult to assess. You can't even read some of the I think it's probably minute ventilation, but you can't read it. It's not all on one page. You have to kind of scroll down to get that data. Just really, we're not quite there compared to other fields. This is an attempt to make it a little more cohesive or integrated. This is from Decisio Health out of Houston. Actually, Dr. Jenkins was on the advisory board for this system. And what this system does, it basically plugs into your Sunrise or whatever EMR you have, and it kind of tries to put all that data all in one graphical representation. So here you can see, and it's modifiable. Here you can see the heart rate over the last 4 hours along with the blood pressure. You can see that about an hour ago, the patient had a tachycardia, kind of stayed up as well with hypertension. You can put bundles into it, so you can tell it what to look for in the data to give you a red, yellow, or green light, depending if it's fulfilled your criteria for whether it's sepsis or Foley documentation or heparin-induced thrombocytopenia or renal prevention, DVT, et cetera. You can see all these are green, so automatically you can go to this view and know that your nutrition is taken care of, your central line issues are taken care of, whatever it may be that you told the computer to do. Abnormalities are in color, so you know the white count's abnormal as it's red. The platelets are green, so normal. But this is an attempt to kind of integrate some of that data all in one view to facilitate patient care. There have been other attempts to involve or include physiologic data in graphical representation. This is from Hamilton Medical on top. It's a ventilator company. And what they do is it's actually, I couldn't get it to move, but it's actually a movie where each time the diaphragm contracts, this comes up, and then it disappears when it's not. When respiratory compliance changes, this shape changes. When airway resistance changes, when it's a high airway resistance, the bronchioles will get smaller. When they're higher, they get, or they're slower, they get bigger. It gives you cuff pressure estimation, et cetera. But it's trying to put all that data in a quick graphical representation. You can just look at it and know the status of the patient. The bottom one is from Edwards. I think many of us in this room have seen this. They implemented it in their Visualeo system. Again, it's just a graphical representation of physiologic data, the same numbers, but now you kind of have a more just one picture idea of where the patient's at. There have been some attempts to change how we kind of evaluate the same information. None has really become standard, but there's one example that I thought was interesting. This this is basically all clocks. These are all 12 hours. So right now this is pointing at 5:30 p.m. So the previous 12 hours are behind here. This represents oxygenation, minute ventilation, heart rate, mean arterial pressure, and cardiac output. As you go through, if you see any blue, that means that they're hypoxic. So this is the area of normal. This is the area of low values, and out here is the area of high value. So you can tell the patient was hypoxic for at least 2 or maybe 3 time periods throughout the last 12 hours. Their minute ventilation has been relatively normal, except for a time period here where it was high. Yellow represents an abnormality, so you can tell they're tachycardic and they have a high cardiac output. And they've been tachycardic for most of the last 12 hours, represented by this orange mark here. You can tell the patient was on minimal oxygenation because these bubbles were half filled throughout this whole time. So just an attempt to kind of put the same information we use on a daily basis, but graphically to be more easily appreciated. Using this, this is actually part of a study, but it was a small study of 8 fellows in a simulated lab setting. And using this data, as opposed to their standard monitors, they were able to make decisions 2 seconds faster in certain outcomes. Really not a significant study. I mainly presented it more just for the system they developed. So are these worth it? Well, it's really kind of unknown. As you see a general theme here, the data is just not very good. This is probably the best set of data looking at graphical or physiologic monitoring displays up to 2007. Look at 31 studies. 30 out of 31 reported significant improvements. They found faster detection of adverse events, improved accuracy of diagnosis or clinical decision-making, and decreased mental workload. It was easier to use these devices than their standard. However, there are significant limitations with these studies. All of them were small size. Publication bias, you're really going to only usually get published what has positive outcomes, especially since 30 of 31 showed positive results. These were all done in labs or patient simulators, so really are they valid in the clinical care setting? And really they only looked at anesthesiologists and nurses. And first I thought, well, that's odd, why wouldn't they look at anybody else? Well, it turns out nurses are the ones that look at monitors the most of anybody in this room. They do it every day, especially critical care settings. That's really all they do is look at monitors throughout the day. And anesthesiologists, same thing. For critical settings, during a case, they should be looking at monitors for most of their time. So that's why these areas or these fields are under focus. So let's take a look at all clinical decision support, not just the 3 I talked about. And is there improvements in outcomes or performance? So this is out of JAMA in 2005. They looked at 100 CDSS studies through 2004. And again, this is looking at all of them, not just expert systems, information displays, but also looking at point of care programs, medication assistance, et cetera. But they looked at evaluating clinical performance and outcomes using a clinical decision support system or routine care. The majority of studies, about 65% or 64%, showed some improvement in physician performance. When you looked at criteria such as improved diagnosis, improved preventive care, improved disease management, drug dosing, or drug prescribing. Only 13% showed improvement in patient outcomes, and actually none of them, 0, showed improvements in mortality, which is really what's supposed to be our ultimate goal. In 2014, a second systematic review came out looking at more recent data. Remember, in 2009 was when the government gave $27 billion to promote EMR. So now there have been a lot more in place, and along with that, more studies. And they felt that the broad definition of CDSS has really made it difficult to come up with a decisive understanding of whether they work or not. So you looked at only randomized controlled trials. Remember, most of the other studies were small, really not very significant. Took at 28, and they only looked at 3 critical outcomes: morbidity, mortality, and economic outcomes. You see the number of studies associated with each there. And there's a forest plot looking at morbidity. For those of you that have not used a forest plot or not familiar with it, these are the studies on the side. There were 9 studies looking at morbidity. The line in the middle is a line of null effect. So each study has a line with the confidence intervals. You want your confidence intervals to not cross the line of null effect to be valid. And the size of each dot actually represents the size of the study. So as you can see, a lot of small boxes here, relatively small studies. But overall, looking at the 9 studies that are available, randomized controlled trials, there was a benefit in morbidity for about 18% when you, depending on which effects model you used, but the best one showed an 18% improvement using some kind of clinical decision support system in your hospital. We're looking at mortality, a little bit different. There are 18 studies in this group. Again, if you look at the boxes, fairly small, so small studies. Most of them cross the line of null effects, so really not very helpful in determining a conclusion. And in general, here's the overall, it crosses the line of null effect, really not valid. So really not, CDS-SES was not associated with mortality. And their conclusion were that CDS-SES with the electronic health record does not affect mortality and might moderately improve morbidity outcomes. Might being the key word there, we're still not sure. Really no difference in cost when you took a look at the economic studies. There's a significant bias in most of the studies. A lot of them were small, underpowered, et cetera. So differences in mortality may exist in particular settings, specific diseases, but overall, no effect on mortality and maybe might improve morbidity. So after all that, I showed you a bunch of, or several not great studies. Should we be using CDS-SES? Well, it's kind of difficult to evaluate overall whether it's effective. It's really, the definition is very, very broad. The studies kind of lump everything together, so it's hard to tease out what works and what doesn't. Many are single center. They're small, so very difficult to kind of come up with a conclusion. Overall, the majority of the data suggests that it improves processes. You can improve adherence to your guidelines, improves your preventive care in the outpatient setting, and your medication errors, particularly antibiotics, can be helped. From an outcome or from a performance perspective, physicians do better in whatever metric you kind of place to evaluate them with. Still questionable as far as outcomes, morbidity and mortality, questionable as far as cost savings. And maybe there's other metrics we need to use. Maybe it's time that it takes you to round in the ICU and you have a graphical representation. Instead of taking 20 minutes collecting the same data, maybe now just takes you 10. And now you can have increased RVUs, et cetera. It's still to be determined. Here's a common cartoon with a patient with an arrow in his back and his physician using a computer system, rapid pulse, sweating, shallow breathing. According to the computer, you've got gallstones. And that's a real life issue. Is a computer always going to be right? So that brings up the legal and ethical issues associated with this. Computers are not a substitute for human decision, and that's actually promoted by both sides, the folks that promote clinical decision support, as well as those that are against it. It really is not a substitute for human decision making, but there's really a liability. Who's liable for using it, not using it, or using it inappropriately? And using it inappropriately could be that now you don't, right now physical exams are not as common as they used to be. But now from a computer system, you have all the patient's data. You can plug it all into a computer system and you can come up with a diagnosis without potentially not ever seeing the patient. So that would be an example of misuse, but who would be liable for any of these? And then it comes down to, is it a service or is it a product? Now we're getting into the legal world where we provide a service as physicians, and so we're held to the standard of negligence. If it's a product, like a toaster, and it burns up your house, that's product liability. So is it a service or is it a product? When you're using these, they're a completely different set of laws. And it's still very, very unclear as to what the end result is going to be. And then it's going to impact your doctor-patient relationship. There's a concept called computational fallacy, that if something pops up in your computer, it must be correct. When I do my taxes on TurboTax and a number comes up, I'm going to say it must be correct. I know it's not true because it all depends on what I put into it. But looking at that, most people will assume that a computer result is better than a human result. It's not necessarily true. And now, do you have to disclose it to your patient? That now this is the way we determine your diagnosis. The computer said you have this. Or if you decide to go against the diagnosis, do you then have to tell it to the patient? And then extending even more, patients will have access to this at some point. There are some programs that are available online where you can come up with your own diagnosis, WebMD, et cetera. And the patient may come in already with a diagnosis, and if you defer from it, or differ from it, that could be a potential issue. So these are all things that are still to be determined. There's no clear answer. So grand challenges in clinical decision support. This is from a group that came up with several things we need to do. One is improve effectiveness, so better interface, better patient summary, and better integration of free text. Creating new interventions, so the knowledge base needs to be updated, ability to learn from itself. and able to disseminate this knowledge. It can't just be one hospital, one clinical support system. You need to have best practices that were shared with other hospitals and have able to pull data from repositories that are online, which are continuously updated. So I'm going to talk a little about predictive analytics for the last part of this talk. It's essentially a statistical analysis of data to make future predictions. Again, not a new concept. It's a new concept in medicine, but not a new concept overall. Your credit scores, predictive analytics. They have predictive analytics for when you send a child suspected of being a victim of child abuse home. They actually have algorithms to predict the likelihood of you being abused again. Aircraft industry can predict when struts are going to fail or equipment's going to fail. So it's really just not being used in medicine. For clinical care, it's usually been used for comparing ICUs and research standardization, not necessarily for bedside clinical care. Some of the examples are the Apache score, which we're on the 4th version now, which takes 129 variables and uses population statistics to give you an expectation of mortality or length of stay. Mortality prediction model, the SAP score, SOFA, and QSOFA. These are all examples. However, none of them are designed to be used for bedside patient decisions. They're based off population studies of mixed general ICU and surgical ICUs. So really you can't apply it individually, but you can have an idea of outcomes. And there are newer models that are being developed that can be used in clinical decision making. One of those is a Rothman Index. So Rothman Index is it's from a company called PRA Health that actually was purchased by University Hospital about 3 years ago. It's actually on Sunrise. And this all developed from Florence Rothman, who underwent mitral valve repair and then slowly progressed postoperatively over the next 10 days and died. And her family members, 2 sons, Michael and Stephen Rothman, who were both statistical engineers, they actually work with big data doing predictive analytics. They saw their mom decline every day because they were there every day, but the hospitalists that came in really didn't appreciate the slow gradual decline until she eventually died. And they said, why can't there be something that you can look at that actually will tell you the state of the patient compared to yesterday or maybe last week and give you an idea of patient status. So they started looking in 2003 at EMR data. And not just the basic data we used, they combined it with nursing assessments. And we'll talk why it's important in a second. It's a composite score, 26 criteria, goes from 0, which is basically you're almost dead, to 100, which are normal, including physiologic data, lab data, and nursing assessments. It automatically updates. It links with your Sunrise database. And as soon as enough of the markers are available to go into the algorithm, it'll update a score. This is what actually collected. It's all the same things we look at as far as diagnostic data, diastolic blood pressure, BUN, same labs. The Braden score is a score for skin breakdown that's also included. And then the nursing assessments. Nurses assess patients every day for all these variables. And why is that important? Nurses do head-to-toe assessments every day. It's part of their standard nursing school curricula. They basically what's called charting by exception. They only chart when there's an abnormality. It's either for each of those standards, food, nutrition, or respiratory, et cetera. They have a certain set of standards that if they've met it, they basically check the box that it's met. They only document if it's abnormal. So for the GI standard, let's say, the abdomen soft and non-tender, bowel sounds are present, no nausea, vomiting, incontinent, the patient has met the standard. If not, they'll put something in. It turns out that if you look at nursing evaluations in relation to both 30-day and 1-year mortality, all of these nursing interventions, regardless of which one you look at, food, respiratory, et cetera, correlate actually very well with 30-day and 1-year mortality. And the Rothmans actually use that as a part of their Rothman Index. So, like I said, there's actually something you can pull up on UHS. When you go into Sunrise, one of your tabs up top is Paratrend. And you can click on any of your patients, collect on every patient in the hospital once enough data is generated. And this is what comes up. It's basically a graph. Depending on how long the patient has been here, you can go back to their entire stay, which gives you a score of 0 to 100. Anything below 40 is considered ill or severely ill. 40 to 65, the yellow line here, is moderately ill, and above 65 is considered pretty good. As you can see, this patient came in moderately ill, then improved, stayed improved, then dropped, and then again dropped here. You can click on any of these buttons, and it'll give you what generated that data. As you can see here, as far as some of the nursing documentation, they did not meet their food, did not meet their neurological, not meet their safety, and they have some other abnormalities with the labs. And what this will tell you is basically you're going to score 0 to 100 where the patient is that day. You can use it for triage. So it's been used by University Hospital rapid response teams to kind of, in the morning when they want to look at any critical patients in the hospital, they'll pull up all the wards and they'll pull up all the Rothman Index values for entire ward. They'll address the ones that are in the red because it'll kind of qualify that for you. And they actually will go by, evaluate the patient. If there's some intervention that needs to be done with the nurse, they'll do it. And they claim that looking at a 6-month period, before and after, they dropped their code blues about 30%. Now, it's a before and after study, not very scientific. But in general, they've reported an improvement in outcomes triaging patients using this data or system. So what does available data show? There aren't that many studies with Rothman Index. It's really only been out a few years, only at particular hospitals. This is from Yale, where actually it's been used the most because the Rothman Index, or the Para Health company, is also right out in New Haven. And there's what